Good evening. Good evening. Okay, well, welcome to the ongoing series on global health challenges for the 21st century. I am indeed honored to welcome all of you to this evening's event. And today we have Dr. Joseph White, a Luxembourg Family Professor of Public Policy and Director for the Center for Public Policy Studies at Case Western Reserve University. Joe comes to us, at least we were talking over dinner. He went to University of Chicago where he got his BA in political science. And then from there he left and went to University of California at Berkeley for his master's and doctorate in political science. In terms of his research, he has published 3 books, co-edited 2 books, and also published over 6 dozen articles and book chapters. His work can roughly be divided into 5 related categories. He is interested in budget politics and policy within the United States. He looks at comparisons of healthcare policies across rich democracies, the politics of healthcare reform, controlling healthcare costs, and both politics and policy for Social Security and Medicare. His most recent research also has 3 aspects. One is his contribution to the Organization for Economic Cooperation and Development, OECD, Joint Network on Sustainability of Healthcare Systems. The second work that he has been involved with involves healthcare policy and forums in the United States. The third book is in progress, and he's looking at issues of U.S. federal budgeting. Would you please join me in welcoming Dr. White?
Okay. It's not recording yet. Yes, yes? Yes, yes. Okay. You would have heard me anyway, but this way it gets recorded. Thank you very much, Professor Cray, for inviting me. Thank you for coming on a night when you could learn about China. China, in terms of the United States, is a problem. In terms of itself, is sort of a success story. I'm not sure what to say about healthcare systems. But as Professor Cray said, this topic is something I've worked on as part of the Organization for Economic Cooperation and Development's joint project between the Senior Budget Officials Network and the healthcare group at the OECD on the fiscal sustainability of healthcare systems. And I want to emphasize that absolutely nothing I say should be associated with the OECD or any senior budget officer of any OECD member country or anything like that, because I probably disagree with a lot of people about stuff. This is just me. Although, I have been involved in a number of the meetings, and I have a chapter in the book they put out. And if you really want to read a lot about this topic, the OECD did put out a book on this in 2015. So why am I talking about this, other than that I know something about it? Because I was asked about possibly talking about something that was global health, and although people, when they talk about global health, they often really mean poor countries, actually. A lot of the globe is actually sort of rich countries. Not most of it, but a lot of it. And rich countries, have problems too. And the policies in rich countries affect the people there. We're one of them, by the way. But they also, sort of slop over to the rest of the world too, because rich and powerful countries have influences on everybody else. And for the last 25 years or so, both in American politics and sort of the international elite discussion of things, there has been this talk about the sustainability. Well, it's really come from 2 points. One is the sustainability of healthcare systems, and the other is, can we afford an aging society? And the idea, healthcare systems are part of that latter story, because the idea is that as the population becomes, on average, older and older in countries, healthcare costs go up to a point that, A, to a point that is harder and harder to pay for in general, but B, because you have fewer, and, because a smaller portion of the population is working, you've got a smaller portion of the population paying both for pensions, for the retirees, for the older people, and for health care for the older people. And so this takes 2 forms in standard political debate. One is in the United States, some of you may have run across, but most of you hopefully are innocent enough not to have. US budget hawks, people who care a lot about the budget, are continually predicting doom due to so-called entitlements. Entitlement programs are things like Social Security, Medicare, Medicaid, and so on. This was particularly promoted in the 90s, both the Congressional Budget Office and what was then called the General Accounting Office and is now called the Government Accountability Office, because when they changed the names, they didn't want to change the initials. So the CBO and the GAO decided one way to make people worry more about budgets was to come up, budget deficits, was to come up with long-term forecasts that showed the world collapsing due to budget deficits 30 or 40 or 50, well, so the US economy collapsing 30 or 40 years in the future. And this became essentially conventional wisdom in Washington. If you were to read the Washington Post, you would notice this pretty quickly on budget stories. So it's really coming from centrists, so-called, like the Committee for a Responsible Federal Budget, the Bipartisan Policy Center, the Brookings Institution, and so on. But of course, it's an argument that is also made by conservatives like the Heritage Foundation. You know, Republicans in general talk about the deficit more than Democrats do. Democrats actually, sorry if this sounds partisan, have maybe paid more attention to it in terms of actually trying to do something about it than Republicans have, but Republicans make it a much bigger issue, and that's a whole other topic as to why it is particularly at the emotional level a Republican issue. The thing to understand right now is that worried about the ability to pay for so-called entitlement programs like Medicare and Medicaid is a centrist concern in the United States. It's an establishment concern, what Paul Krugman calls what's the term? I'm losing the term, but what I call the party of responsibility. Responsible people think you're supposed to worry about this. Now, other countries spend a lot less on healthcare than we do, but there's still lots of worries, which is why there was an OECD project on the fiscal sustainability of healthcare systems. Really, it traces back particularly to 1994 when the World Bank issued a study called Averting the Old Age Crisis, because there was going to be an old age crisis, and then the crash of 2008. So you have the IMF, you have the OECD, other leading organizations worrying about fiscal sustainability, and the basic idea is, wow, healthcare is costing more and more and more, and how are we going to pay for that? And so there's a series of issues. One is economic sustainability. Will the cost of healthcare somehow clobber the economy? And that really has three parts. One is there's macroeconomic arguments about the budget, that there'll be effects on the budget which will cause macroeconomic problems. Then there's macroeconomic arguments about hiring and competitiveness. In certain countries, the argument is, and I'll go into this, that the cost of healthcare for employees makes employers much less likely to hire, and that has all sorts of bad effects on the economy. And then there's the finding the money problem. Finding the money problem is actually a problem. You have to collect money if you're going to do this, and you have to find some way to collect it. The ways that countries have been doing this, most countries are getting more and more difficult to make work. And that leads to the political sustainability problem, which is much more real than the economic sustainability problem. The political sustainability problem is that in order to pay for health, the more expensive healthcare gets, the more you have to take from richer people to pay for healthcare for poorer people. That means you've got to get them to go along. And that's not always easy. And the more money you have to move, the tougher it is. And so the real sustainability problem is finding the money from richer people, actually. But why do you need to find the money from richer people? Because in fact, if you look at how healthcare systems were financed in most of the world, it has largely been, historically, from taxes that are not progressive. I mean, yeah, if you're collecting in one way or another, say, 12% of payroll from people, you're collecting more from people who are making 40,000 euros than people who are making 20,000 euros. So there's some redistribution in that sense, but it's not really a matter of really targeting richer people. In fact, the welfare states of most Western democracies are financed by somewhat regressive taxes, by either straight payroll taxes, which stop getting collected at some cap, or by sales taxes, value-added taxes. So we're moving to a point where that's not going to be enough. But why is that? Well, it's because costs keep increasing. And why do costs keep increasing? And there's really three basic reasons, or theories. One is that there are sort of underlying problems of an aging society and of technology that explain healthcare cost increases. And I will explain why I don't buy those much. The second, which I take much more seriously, is that there is a process by which new needs are invented by the medical world, and we keep getting convinced by various social processes that we need more and more medical care. That is real. And the third reason why costs keep going up in some countries is the medical sector is very good at extracting money from the rest of us. In other words, there's two levels of redistribution in healthcare finance. Actually, there's more than two, but for this purpose, from richer people to poorer people, and from all of us to the medical industry. And so you have to think about all those, about that too. And so I'm going to talk about each of these topics and then what can and should be done about all this. So the first thing to point out, you've probably heard of this, healthcare spending grows in rich democracies. And if you were to look, if you could actually see this well, you would see that healthcare spending ranges from 16.6% of GDP in the United States. We win. We're number one. America is the greatest. And then you have Switzerland at 11.4, Sweden at 11.2, France at 11.1. These numbers are from 2014, I think, and these numbers fly around all over the place. Among the countries, like the countries that are real close together, like France and Germany and Switzerland and so on, these numbers sort of wander around. It's a really close race among those countries. But we've got everybody. We're number one by far. And it may not seem as obvious when you compare to the United States, but all of those things are going up, okay? So you have, let's see, the United Kingdom, 1980 was about 5% of GDP and is now about 9% of GDP, gross domestic product, the economy. So healthcare spending grows in rich democracies. I use the term rich democracies because one of my professors wrote a book about it. You can use advanced industrial economies or whatever, but rich democracies, okay? They're relatively rich, they're relatively democracies, okay? I'm sure you can come up with theories that explain why they're not exactly democracies, because none of them are exactly democracies, but you can see this. Another way to look at the data on spending trends is, so here's a press release from the project I was part of. Healthcare costs unsustainable in advanced economies without reform. And what this does is that for each of the countries, the little red diamonds are the healthcare spending growth per capita over the 22 years from 1990 to 2012. And the blue bars are the average GDP growth per capita. And what you can see is healthcare spending grows faster than GDP, unless you're in Estonia. And Estonia doesn't really count. It's a really small country that had just gotten free from the Russians, and sorry, that's no. Now I do want to emphasize something. Healthcare spending buys stuff. It buys life in some cases. My wife would be dead without modern health care. She had a condition that required open heart surgery 7 years ago. There's no way in heck she could have lived without that. Now, if you do global health stuff, you will learn that there's a lot of different things that affect life expectancy and affect health. And medicine is only one of them. So one of the things you learn is if you want to, for instance, compare health outputs, it gets difficult to do because let's say you look at life expectancy, or let's say you look at infant mortality. There's all sorts of things that affect infant mortality other than healthcare. So what a bunch of people did was they came up with, some scholars did, was they came up with what they call mortality amenable to healthcare, which is how many people die of stuff that we know if they got the right healthcare they wouldn't have died of. And there's various, I have it in my notes and underneath here somewhere, more of an explanation of what's in here. But so there are things, for instance, that people die of, but you really couldn't have done much about for medical care. Lung cancer, getting hit by a truck. Right? But there's things you could have done a lot about. People shouldn't die of asthma. And there's things that are, so they do something, so this includes diabetes, stroke, bacterial infections, among other things. So ischemic heart disease, some people should die and some don't, so they counted half of the ischemic heart disease stuff. And the thing to see here is that in any country, some people die of stuff that could have been handled by healthcare. But the white bar is what the figures were in 97, 98, and the burgundy, maroon, bar is what the figures were in 2006 or 07 for various countries. And you can see that everywhere those figures are going down. Healthcare is doing more good as the spending increases. Maybe not only because the spending increases, but there's progress being made. The unfortunate thing is, of course, the United States is the one at the right there, which means that we have more people dying of things they shouldn't have died of than all the other countries in this comparison. And we have made less progress relatively than all of the other countries, except I guess maybe Greece. So that's not good. But it's important to remember that healthcare does help people. Other things are important too, but we're getting something for the money. Now, I said earlier at the beginning that there was this issue of the aging society, and this really is hard to follow, but the basic idea here is on the left is population aged 65 years and over, on the right is population aged 80 years and over, and the dark is, the light is the population share in 2010, and the dark is the population share in 2050. You'll notice it doesn't go down, right? So more old people by any definition everywhere. It's important and you can see that this is what the worries about the aging society come from, is these projections that there will be more and more really old people. And old people in general have more health problems and therefore more health expenses than younger people. So if a larger proportion of your population is older people, that should mean more demand for health care. Logical enough? It's even true. One thing to point out here is that the United States is almost at the bottom of this list. The United States is the 8th country up. It's slightly older than Australia and Turkey, but younger than, say, the Russian Federation, Chile, Luxembourg, Brazil, Latvia, Norway, Iceland, Denmark, China. Younger than China. So the United States has a relatively small aging problem. Why is that? Partly we have a few more kids, partly because we have more immigrants, partly we have immigrants who have kids, but partly our life expectancy isn't as great as in a lot of other countries because for a series of reasons, including that some people don't have health insurance. But for whatever reason, there's a series of reasons why the United States is projected to have less of an aging effect in terms of population statistics than other countries. But everybody has it, which is why you have the OECD and the EU and everybody doing their studies. Okay. So what's the problem here? The first set of problems when we talk sustainability, usually when people talk about sustainability, like everybody at the OECD meetings, they're talking about the economy. They think they're talking about the economy. And so the underlying theory is that out-of-control healthcare costs are going to do things to the budget, and then the budget will do something to the economy. So what are the budget theories? Well, theory number one is just deficits are evil. That's probably the theory you would get from talking to the average American voter. Sorry if it bothers you, but no, deficits aren't evil, and they don't have any immediate effect on any economy. Look, governments, states are like households and firms. They can borrow as long as they want, so long as they can pay the interest. We don't think about it this way, but many households have deficits. They went out and they bought a house, and they owe a lot of money for the house. And what happens when they get richer? They buy a bigger house, borrowing more money. And why is that? Because what matters is whether you have a reliable flow of income that you can use to pay the interest. Firms can also borrow. The question, borrowing is not evil. We may overdo it in a lot of situations in life, but it is not evil. It can be unaffordable, but it's only but that's the question, is can you afford the interest that can be projected that's reasonably expected from the borrowing? So if deficits aren't simply evil, then what could the economic effects be? In the 1980s and the early 90s, an argument was invented really by mostly moderate and some democratic economists, and became really dominant among a lot of economic thinkers, both internationally and in the United States. And what it said was the United States did not have enough savings. The United States was not saving enough. And because it wasn't saving enough as a country, it wasn't investing enough. And because it wasn't investing enough, productivity wasn't increasing enough. And because productivity wasn't increasing enough, economic growth wasn't increasing enough, and people were feeling poor and miserable. Each of those steps of the theory makes some sense. That should go in the right direction. Now, therefore, more national savings would increase investment. So how would you get more national savings? Well, national savings is the sum of savings or borrowing by firms, by individuals, and by the government. The people who were talking about this were talking about the government budget. Government isn't all that good about getting firms or individuals to save, but their theory was the government knew how to save for itself. They were sort of wrong, but that was the theory. And the idea was that we're going to stop running budget deficits at least, or maybe even have the government run surpluses, and that will increase national savings, because it's just one component of the total, and that is going to lead to a bigger economy, and everybody's going to be happy. Okay, problems with the theory. The major problem with the theory is that most of the government savings don't become private savings. Why? Offs don't become national savings because they offset from lower private savings. Why are they offset from private savings? Well, how does the government change its budget position? It taxes people or it cuts spending on programs. What do people do when their programs aren't being spent on or they're being taxed? Well, among other things, one of the things they do is they save less themselves because they were in worse shape to maintain their current consumption. So a lot of the changes of any policies that increase government savings are going to show up as decreases in private savings. The second thing is, of course, that it doesn't show up as investment because some of our investment is financed by flows from abroad. And if there's more money in the U.S., what's likely to happen is the money in the U.S. goes into those investments, but the flows from abroad don't. So you get, it's on the whole, I'd rather have Americans investing in America than foreigners because then the profits get paid to Americans rather than foreigners. But I don't want to sound too much like a certain eminent politician. But nevertheless, you aren't really increasing investment by as much as you increase savings, and you aren't increasing private saving, your total savings, by as much as you increase government savings. And so the standard estimates was about 30% of the money from the extra government savings would actually show up as investment, which really wasn't a very big return. Not only that, but growth is not so strongly related to investment. All sorts of other things affect growth. For instance, in the middle of the 1990s, productivity increased dramatically, in spite of the fact that national savings hadn't increased. Whoops. So the bottom line is that the economic arguments about we have to worry about government saving, about healthcare spending because that affects the deficit, and the deficit affects government savings, and government savings affects national savings, and national savings affects investment, and investment affects productivity, and productivity affects economic growth. If you actually try to, say, the Congressional Budget Office or the GAO or various eminent economists actually try to estimate it, it's just not that much. Not a crisis, not a big deal. It'd be nice, other things being equal, but it's not a big deal. So particularly in the early 1990s, since that argument wasn't working, the CBO and the GAO and some economists started talking about long-term crisis. And the logic, and you will just go on the Center for the Responsible Federal Budget or all sorts of other websites right now, you'll see the exact same arguments. And the idea was that if you run deficits and you don't do anything about them, then you have higher interest costs. And if you have higher interest costs, then next year you have bigger deficits. And also you're going to have to keep rolling over the debt, and as you roll over the debt, you're going to have to borrow more to roll over the debt. And eventually you got really big deficits. And by the way, and so not only are you soaking up a lot of the capital in the economy for your deficits, but people get less likely willing to loan you money, so they want to charge a higher price for the money, and interest rates go up. So the government is soaking up a lot of the capital in the economy, which is no longer being used productively, and interest rates go up, which has a horrible effect on investment too. And eventually you end up, and meanwhile the government gets deeper and deeper, another day older and deeper in debt, and eventually can't pay its bills. So eventually, the high interest rates crunch the economy. The debt gets even worse because high interest rates crush the economy. Eventually, you either have default or much less consumption and investment. And the strong version of this was the CBO and GAO stuff about long-term disaster. And the weak version of this was the IMF and the OECD talking about fiscal space. Now, again, what does healthcare have to do with this? Well, if you actually had increasing healthcare costs but actually paid for the healthcare, there'd be no effect whatsoever. So it's always assuming the healthcare spending goes up, but you don't pay for it. Another problem is that we had a little experiment in 2008 about the extent to which being responsible about budgets by running surpluses, say, had much to do with what happened to your interest rates. And the answer was it had very little to do with what happened to your interest rates. The United States was relatively irresponsible about budgets, proceeded to run deficits of 10% of GDP because American policymakers thought, that's probably a better idea than crunching the economy even further, so let's have what's called demand management and demand stimulus. The Federal Reserve encouraged this, and American interest rates fell to a nearly all-time low. So we actually managed to double, roughly, our national debt and halve our interest costs because the interest rates fell by a factor of about 4, roughly. Not quite, but really happened was we rolled over our old debt and paid for it at low interest rates. And so we were totally bad actors and didn't get on the interest wheel at all. Meanwhile, places like the Spanish and the Portuguese, who've been running budget surpluses, they got clobbered. So again, lots of other stuff going on. And besides, you can tell the story about governments getting into this mess, but they have to do very little for a long time. And it's important to remember that, by the way, the United States did balance the budget in the late 1990s. And a lot of governments do eventually balance their budgets. And, normally they don't get on the interest wheel. They might even find some way to control healthcare costs. They might even decide to pay for healthcare costs. They might pay less for their military. The healthcare costs are unsustainable because the healthcare costs are economically unsustainable because of the budget. Healthcare costs are economically unsustainable because of the budget, because we're not going to do anything about them, either in healthcare or in anything else. And it's not a really tremendously convincing argument. So then there's the effects on employment. And let's say an employer pays to the cost of healthcare. And there's really 2 ways that happens. If you're in Germany or Belgium or the Netherlands or a number of other countries, you basically have sickness funds, and employers are required, employees and individuals pay a portion of their income, of the wage flow, as a percent, required contribution towards the funds for health insurance. We have a version of that in Medicare. Employers pay 1.45%, employees pay 1.45%. If you wanted to do national health insurance, Medicare for all, multiply that number by about 6, okay, you're home. People might not be happy, but you're home, okay? And of course, in the United States, employers aren't mandated to participate, but lots of employers do pay for a lot of health insurance for their employees. So then it's arguably, this is a labor cost. And every time you hire somebody, you're taking on this cost as well as their wages. And as one German study said, how high can non-wage labor costs be raised without affecting international competitiveness? So you can see how, if it's coming out of employment, this could change employer behavior and lead to less hiring. Right? There's something to this argument. So what are the problems? Well, one thing is, if you ask your standard macroeconomist, or microeconomist even, they'll say, wait a minute, employers don't focus on wages, employers and healthcare separately. They focus on total compensation bill, and they pay whatever they pay. So if they're paying more for healthcare, they'll pay less for wages, and that's what they do. And they claim that there's absolutely, that the health insurance doesn't raise costs at all. This is part of why they also claim that if employers weren't paying as much for health care, that everybody's wages would go up. Same argument. There's only two groups of people in the world who don't believe the economists on this one, employers and workers. But there's something to the economic theory. It's not entirely right. Okay, but it is partly right, only partly. And it's a factor to think about. A bigger factor is healthcare employs people too. So not only does healthcare employ people too, but the jobs that are employed in healthcare are probably harder to outsource than a lot of other jobs. So if extra money goes for more services, as opposed to just raising pay for hospital executives, if you put in extra money and it goes for more services, then on balance that may increase employment. And the most thorough study of this was done by the German Advisory Council for the Concerted Action. And the person who was chair of that advisory council at the time spoke at one of the first OECD meetings in this project and said, there is no optimal health expenditure quota. You can't just look at the effect on employment and without remembering that it has two sides. The money spent on healthcare actually hires people too. So on the whole, I don't think it's reasonable to talk about the unsustainability of healthcare in terms of macroeconomic effects, either the budget or effects on employment. You want to worry about things? Worry about automation. Worry about globalization. But if you're in a rich country that has high wage rates, that'll have an effect on hiring in the country. But healthcare, not so much. Another way of putting this is it doesn't matter what the Dutch do with their healthcare. Workers in Indonesia are going to be cheaper. Now, the real problem economically is finding the money. This is a problem because healthcare costs a larger and larger share of national income. You saw that chart, share of GDP. That's a large share of an economy to collect. And in per capita terms, if you weren't doing some sort of health insurance in which there were subsidies from richer people to poorer people, you'd have a lot of people who can't afford it. In the United States, in 2015, per capita health spending was 30% of the median per capita income. And you can look at it in other ways, because those are sort of weird statistics. But just think of it this way. The average health insurance is going to, for a family of four, is going to cost $15,000 to $20,000. If your family of four is living on $45,000 a year, there's no way. So you're going to have subsidies. And the more expensive it is, the more subsidies you're going to need unless you have people not getting health insurance. But it's worse than just the increase in total spending and the relative to the size of the economy or national income. Because in most countries, some substantial portion of the finance of healthcare is from wage income. In all those sickness fund countries, and certainly in the United States. And wage income, for various reasons having to do with the development of international capitalism, blah, 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 wage income is a steadily falling share of total income. Between 1990 and 2009, it fell from a median of 66.1% to 61.7% of national income. This is, when you start seeing this, hearing this stuff about growing inequality around around the world, among the rich countries, this is the most fundamental part of it. So you're going to need to redistribute more from higher income people to lower income people. Higher income people don't like that. Higher income people in most countries have more political power than lower income people. Historically, the best way to collect money, by the way, for anything in government was to hide the collection. So the main reason why why government spending is higher, or one main reason why government spending is higher in a lot of European countries than in the United States is they collect taxes in a much less visible way, through a value-added tax. They have other taxes too, but they tend to have much higher consumption taxes than we do through the value-added tax. It is regressive, but people don't see it because it's just sitting there in the price. It's not visible like a sales tax is. In the US, of course, a lot of healthcare spending is invisible because the employer is paying it, and you don't know how much the employer is paying. So you have the value-added taxes in some countries, you have the employer contributions in the US, but the trouble with the employer contributions in the US is they're not invisible to employers. They may be invisible to voters, but they're not invisible to employers, and employers have been steadily cutting health benefits, either dropping insurance coverage or creating much higher cost sharing, high deductibles, and so on. So one of the reasons why people don't think that the Affordable Care Act did them much good is it didn't do most people much good. Those people who were getting insurance from their employers and who kept getting insurance from their employers, if you lost insurance from your employer, it did you good because it gave you an alternative. But if you kept getting insurance from your employer, the insurance kept getting more and more expensive and worse and worse. That's been going on as costs go up. It's important to remember for healthcare that there's really three kinds of redistribution. From the healthy to the sick, which is accepted everywhere except sort of in the United States. In the United States, we have pre-existing condition exclusions, we have higher insurance premiums for people who have been sicker or who are older. That's called experience rating. But as it gets more and more expensive, the subsidies from the higher to the sick each year, from the healthy to the sick each year, have to get bigger. It's from richer to poorer. And what I've said is basically, historically, in any country, most people have paid the same share of their income, but that actually is redistributive because somebody who makes $100,000 a year doesn't have twice as much healthcare need as somebody who makes $50,000 a year. You think of yourself as a liberal, that's okay. It's not progressive taxation, but it's still okay. It's good. But now it may need to be progressive. And then, of course, there's redistribution from consumers to providers, to hospitals, doctors, drug companies, medical device companies, nurses, orderlies, techs, allied medical professions, administrators, and billing clerks. There's lots of jobs. Some of those jobs are high incomes. Some of them are quite low incomes. The United States has this crazy health insurance system in terms of efficiency. And the effect of that crazy health insurance system is that the Cleveland Clinic has, according to a story in Newsweek in 2009, which was praising the Cleveland Clinic and how wonderful the Cleveland Clinic was, and mentioned it had 2,000 doctors, which is really pretty darn impressive. That's a big system. And 1,600 billing clerks. And I was in France on sabbatical, and I would say this at a couple, some talks I gave, and they'd say 2,000 doctors. I'd think, wow, that's pretty impressive. And then I'd say 1,600 billing clerks, and the basic reaction was, what? Are they out of their minds? What do you need 1,600 billing clerks for? Well, because of the way the insurance system works. You have a single payer, most of those people go away. That's a whole lot of actually low-income people, lower middle-class people. So a lot of greedy, richer people would lose money, but so would some not-so-greedy people who just happen to be doing something that looks useless in any other country. The point about all this is how much we distribute to providers is a political choice. If you redistribute more to providers, you're making healthcare less sustainable for the patients. So where's spending increases coming from? Maybe the aging society, and it is true we will have larger proportions of older people over time, and older people cost more. Back in the mid-90s, a guy named Peter Zweifel, who's this sort of market-oriented, semi-conservative Swiss economist, eminent health economist, said, wait a minute here. And he started arguing that aging is a red herring. And what he pointed to was that if you look at, why are 80-year-olds more expensive than 70-year-olds? And the answer is that generally, the difference is that 80-year-olds are more likely to go through a final illness. And final illnesses tend to be really expensive. In other words, a lot of the difference between 80-year-olds and 70-year-olds is that 80-year-olds are more likely to die. And when you die, that usually is associated with a lot of healthcare expense. By the way, the most expensive healthcare cases, half of them are people who die, and half of them are people who don't. So you can't say, well, we should just let them die, because you don't know which ones are going to die. Okay, but in general, you've got a lot more people who are 80 than 70 who are going to die and therefore have the expensive illness associated with dying. Why does this make the aging argument a red herring? Because you look and you say, well, they're going to have a lot more 85-year-olds than you did before. Why? Because a lot of the 65-year-olds and 75-year-olds are living to be 85. But that means the 75-year-olds who don't, if more of them are living to 85, then the 75-year-olds aren't as expensive as a group as they used to be. Because fewer of them are dying. As I say, if people live longer, fewer must die at the younger ages, which means that, so you've got an age distribution that looks like it will be more expensive, but the expense at each age group has changed also. It's also true that at some point, systems start spending less on people who are older, even if they're dying. More 90-year-olds means less is spent on 85-year-olds, but costs associated with dying tend to decline among the very old. And also people are in general getting healthier. There's some what's called compression of morbidity, some. Lots of different studies. The balance of the evidence, I think, is that people are sort of healthier in general. And so, the OECD says that the demographic effect only accounts for a small amount of projected increases in public expenditure. It's not trivial, but it's not a crisis. If you were to look at some of these figures, Japan went up a lot, and Japan went up a lot over that period because Japan really did age a lot. And also they've been keeping things costs incredibly low, and finally something had to give. It's not trivial, it's not enough for a crisis. Want to worry about aging and aging's effect on stuff, worry about long-term care. Don't worry about medical care. Worry about who is going to take grandma to the bathroom. So then there's technology. Technology is why spending grows, and that's the main answer from economists. They do studies and they say it's economy. But there's a few problems here. One is, isn't technological advance supposed to increase value in most things? If it didn't increase value, why would anyone adopt it? Greater value might increase spending, but if it increases spending, is that really a problem? Now, it's a problem if you're paying but not getting the benefits. But that's back to redistributing to the providers. So why would healthcare be different? Why would technology not be associated with greater value? And why would anybody adopt technologies that aren't associated with greater value? Now, sometimes what happens is something happens and there is a big efficiency increase. Laser surgery as opposed to using scalpels on eyes. Huge increase in efficiency. You can do the operations with much less time, less expensively, less risk, but you have to capture the efficiency. And if you keep paying the same amount for the surgery that you did before, you don't capture the efficiency. Who captures the efficiency? The ophthalmologists the ophthalmic surgeons capture the efficiency. So you have to set up the system to capture the efficiency, and in a lot of cases, they don't. Then there are cases that look like better value, where something becomes cheaper and safer. But if something becomes cheaper and safer, people are more likely to want to do it. Not just the doctors, but the patients. So let's say you're thinking about whether to do gallbladder surgery, cholecystectomy. And gallbladder surgery is a major abdominal surgery. If you're a doctor, never mind a patient, you're not exactly sure how much the person needs gallbladder surgery or whether you could do something else, you might hesitate to do it when it's major abdominal surgery. Then they invent laparoscopic cholecystectomy. Well, I don't know how that works, but they come in with just not very invasive. All of a sudden, patients are more willing to have the surgery, and doctors think that the indications for doing it increase dramatically. And what happens? You end up spending more on cholecystectomies than you did before because you're doing a lot more of them. Now, by the way, that may actually be greater value if they're actually helping people, but it's also greater spending. And then some new technology is worse value, but that's a policy choice. All sorts of drugs that are added on. I mean, one of the things that drug companies do is they invent slightly different formulations that do more or less the same thing as their old products did, but that they can establish a new patent on, and that don't actually gain much, but they can get a new patent, and so they can charge the higher prices. And they can, and then they run advertisements to tell you that you need this new drug. And they walk into the doctor's office and they do all sorts of things to convince doctors to prescribe the drug. So there are reasons healthcare could be different, but they're all reasons that don't have much to do with technology. They have to do with other aspects of policy. There are lots of ways to influence the cost of new treatments. You can affect the prices. You can affect the supply. You can shape incentives. I've written a lot about this. And also a lot of things that new services that happen are not actually explainable as technology. I mean, somebody's doing something new, but it's not a technological advance. Medicare had a big increase in spending on physical therapy in the 1990s. It's physical therapy. And it's new technology in the sense that they weren't doing much of it before, but the technology had been around for 30, 40 years. So technology isn't a convincing answer, but something that it speaks to is more relevant, which is we do more and more stuff. More and more stuff get defined as part of medicine. We medicalize social and personal problems. ADHD, that used to be just an overactive kid. Alcoholism, that used to be a person's problem. He's an alcoholic. Depression, he's sad. Erectile dysfunction, won't say anything. The point is that these are all now medical issues with medical answers and medical expense. We expand diagnoses. We look for diagnoses. We do more and more screening. We call that prevention. We redefine risk factors as diseases. So we've gotten to the point where cholesterol screening, which was once a way of looking for risks, we now define the cholesterol as a disease. It's hyperlipidemia. It's a chronic condition. And one of the really interesting things is we have two lines of work on Medicare beneficiaries. One says they're becoming healthier, and the other says they have more and more chronic conditions. You really couldn't have a better indication of the growth of diagnosis. And this is very complicated social, economic, and political processes. Get more and more people diagnosed with more and more different things and more diseases eligible for being diagnosed. The research enterprise promises miracles. Just turn on your TV any day. The industries invent services. The media promote cures. Everyone's scared of illness anyway. Doctors tell you what you need. You don't know what you need. You go to the doctor, and the doctor says you need. And the industry does have some political influence. That is part of the story in any country. And so there's all these pressures to say there's more and more care that people need. And then once you have more, there's all sorts of things in the world where notions of need are increased. Cell phones, right? Everybody needs a smartphone. we don't generally think of that as a government problem. So why is it a government problem? I'd say empathy, equity, and expectations. This is the only basic human need for which we have actually socialized finance. There are other basic human needs, food, clothing, and shelter. But this is the only one where basically every country except the United States, through government or something sort of like government, basically pays most of the bills, rather than expecting people to pay it out of their own out-of-pocket income. And there are some technical reasons for that, like you don't know what your healthcare costs are going to be any given year. And so it's not, you can't like save for it. You can't borrow. You happen to get leukemia, no, the bank's not going to lend you any money for the bill, for the bills, and so on. But it's also, I think it's also because we can empathize with each other more. This isn't about health, it's about fear, pain, and rescue. Sorry for people who think that health policy is about health. It's not so much. And in this case, it is easier to empathize with people who are in pain or threatened by disease than people who have less food within limits, or people who have a smaller house. It's a lot harder to justify inequalities in healthcare. Doesn't mean we don't have them, but it's a lot harder to justify them. It's a lot easier to think there but for the grace of God. You know, if you're driving a Mercedes and somebody else is driving a Hyundai, you don't think there but for the grace of God goes I, unless you're really self-righteous and all that. But you know, we have the Jimmy Kimmel test. And that really indicated something. You know, how can you accept somebody else's child can't get that care? That's different. There's less of a sense that it's their fault or their choice that they got sick than there is that, you know, they don't have as high an income to pay for food or clothing or shelter. Maybe somewhat their fault or their choice, but it's a little harder to accept because we all know people who got sick who didn't deserve it. Right. So even in the US, there's lots of redistribution to pay for health care. If you define redistribution or effort to redistribute as what share of the economy is taxed by government to pay for health care, and therefore what share of the economy is basically transferred on balance from wealthier people to poorer people, the United States is 7th or 8th in the world. We just happen to spend just as much money on our inefficient private system. But you know, we actually tax people a lot to pay for health care. We distribute a lot of money to pay for health care. So it's just a lot harder to accept a situation in which some people get what are viewed as health care benefits and other people don't. And then, of course, we have, adding to that, the increased expectations of all the pressures that I mentioned before, both from society and from the suppliers. Even aging can be fixed. So what is to be done in any country? Well, first thing is to remember that costs equal incomes. A classic article on Health Affairs said, it's the prices, stupid. If you're trying to explain the difference between the United States and other countries, it's prices and administrative costs. That's it. But, you know, that means other countries have to watch their prices too. They've just done a better job of it than we have. Try to avoid waste, especially overhead and excess supply of services. You do not need to be having physician groups going out and buying MRI machines. That leads to too many MRIs. Be picky about fads. The health policy world is really amazing. There's so many people in it who generate so many different ideas. There's an alphabet soup, P for P, EBM, EHR, ACOs. You heard about some of these, actually, if you come to some of these previous talks, I believe. I'm pretty sure you heard about ACOs and P for P and maybe even EHRs and EBM. Most of it doesn't work. Whole other story. You have to, in the long run, those other countries mostly do better, but nobody's really good at resisting promotion of need. Now, there's things you shouldn't do. You shouldn't allow direct-to-consumer advertising of drugs. That's just stupid. Sorry. I think the only other country in the world that allows it is the New Zealanders. But it's a lot bigger than direct-to-consumer advertising. Resisting promotion of need really means getting proper limits on coverage. You really should cover stuff that really makes sense as social sharing. Maybe we shouldn't cover erectile dysfunction drugs, for example. So there's a lot of things you can do, but then it's a political choice. I think healthcare is so important that I'd find the money, and that would make it sustainable. But there's a sad bottom line to this story. When I'm speaking to OECD people, I argue that other countries can sustain their systems with some care. They will need to widen their financing because wages won't do it anymore. They'll need to deal with medicalization. And I point out to them, if they want to make arguments about economic unsustainability, they're all at 11 or 12%. We're at 17. Their idea of unsustainable spending is 13 or 14% of GDP, but we're way above that. And by the way, our economy does function. It may not function very well for everybody, but it does function. The very fact that we've spent so much more than all those other countries is an indication that this sort of economic unsustainability arguments are really questionable. But there's another way to look at that comparison. Because from the perspective of all those countries, we've already lost. They're trying to sustain something that we don't have. We don't have health insurance for all Americans. We have the worst performance on preventing amenable mortality. Why doesn't the US have universal coverage? Endless books on that. One is the political system. To get there, you would have had to make big changes, and it's hard to make big changes in the system. Sometimes that's a good thing. If you like people having insurance, we just had an example of how it was a good thing a few months ago. Partly it's ideology. We have a larger share of our influential public that really distrust government. Partly it's the history, because we don't have it because we don't have it. And there's a legacy of both the political system and ideology. But it's also because our care costs so much. We have to redistribute a lot more money. As I said earlier, we redistribute as much money as all but a few countries. And we'd have to redistribute a lot more because we've let the costs get out of control. So what are we doing? We are sustaining incomes in the healthcare industry. We are not sustaining healthcare for Americans. Long talk. Sorry. Questions? Discussion?
I guess the most simple question, which other country's model do you think would be the easiest for us to adapt?
Well, the first thing is, at some level, that's a political question. Right? What could you sell? And here we've got a problem. The thing that is most familiar to Americans is Canada, the so-called single payer. There's a bunch of problems with that model, including that their single payer doesn't cover drugs. I'm not saying it isn't a much better model, way of doing things than what we've got, because it is, but by my values. But that's the most familiar. I would say, to my mind, you can accomplish basically everything you accomplish with single payer by having highly regulated insurance companies who are forced to standardize pretty much the insurance they offer, and then having what's called an all-payer price-setting system, in which there's two different ways to do it. One is in Japan, where the government basically sets the prices for all the different insurers to pay. And the other is in Germany, where the government says to the insurers, hey, insurers, you get together, form a cartel and bargain with the providers who will also form a cartel and negotiate it out. But by the way, if it doesn't come out the way we like it, we'll make some changes. So it's, in either case, what you're really doing is finding an agent for the payers. You have multiple payers, but you create an agent for the payers, either the government directly or this cartel of the payers, who maximize the market power of the payers relative to the providers. And then the standardization of the insurance and the standardization of the billing gets rid of a whole lot of the administrative costs of the overhead. Now the question is, do you have a better chance of getting to that than to single payer? Logically, if you just think in terms of people's interests, it should be easier because you can keep the insurance companies. You don't have to abolish them. But they sort of like existing in their current way. And from the provider's standpoint, it's 6 of one and half a dozen of the other. What the providers don't want is regulation of their prices. You know, that's Armageddon for them, the way they look at things. So you still have all the providers against it, whether you go to single payer or all payer. So then the question becomes, how do you build a movement? Something that would overcome the providers. And it's possible that it's easier to build a movement over single payer than over, well, let's have a regulatory structure of all payer with cartel, blah, 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 blah. Right? Single payer sounds simpler. Yeah. So I don't know the answer.
To build on the previous question based on that answer, so would all payer kind of be like the electricity companies today?
No, because the electricity companies, in theory, are actually, how to put this? So the way if I understand the electric markets, okay, there's more or less one in most areas delivery system. You know, whether it's for gas or for electricity. But then, so you pay a fixed fee to the delivery system, but you have a company that is. But then you buy your supply of power from these other companies, and they are supposedly competing with each other at different prices. So that's different from a situation in which, but the healthcare market is very different from that. And the issue in the healthcare market is if you go to a hospital and you ask the hospital administrator, what do you charge for a cholecystectomy? What do you charge for colonoscopy? What do you charge for a knee replacement? They'll say, to whom? Because they charge 3 times as much to some providers, to some payers than to others. They charge a lot different to different private payers, never mind Medicare, Medicaid, and the private insurers. And if you go to an insurer and say, what do you pay for a cholecystectomy or colonoscopy or whatever, they'll say, to whom? Because they pay 2 or 3 times as much to some hospitals as to other hospitals, never mind what you pay at an ambulatory surgical center. Uwe Reinhardt is the greatest of the health economists. I said bad things about economists, but Uwe's good. Uwe wrote a great piece called something like Hospital Prices, Chaos Under a Veil of Secrecy. There's just so many things in healthcare where we don't know we don't really know what the prices are. Look at issue 2. Issue 2 might possibly lead to the state government paying less for drugs. It's possible that the VA pays less than Medicaid does, than Ohio Medicaid does. Most people think it probably does. Do we know? No. I mean, there have been studies sort of this that sort of have results. We don't know because there's all these discounts and these contracts that are hidden by contract. And hospitals are much worse. So it is different from the utility industry. Yeah.
In regards to your point on doctors giving potentially non-necessary procedures, do you think that there's a role in the fact that a lot of doctors are unaware of the costs of what they're providing or what they're encouraging patients to get? Would there be a way, do you think, for prescribers to be aware that they should prescribe one blood pressure medication versus another?
Yeah. So this is a really tough one. Okay? A lot of theories of healthcare reform would like doctors to manage costs for the system as a whole. And it's based, among other things, on the observation that the most expensive piece of equipment in healthcare in medicine is the doctor's pen. Well, it's not the doctor's keyboard, but because the doctor orders most of the procedures. Part of the problem is that the doctor can't possibly know the price because the doctor doesn't know what insurance the person has. So what that drug would cost that person, never mind what that knee replacement will cost. So you'd have to standardize the prices to get to that point in the first place. Okay, and we're nowhere close to that. Part of it is that we do have insurance. And the point of insurance is to try to get people not to have to worry about the costs. And there are some differences in judgment. There is uncertainty, and people will deal with uncertainty differently. So, for instance, again, my wife was on Topo. There's a generic Topo. Her doctor said, no, don't get the generic Topo. Why not get the generic Topo? I'm a big deal cardiologist. I have so many patients that I think I have a sufficient sample to say the generic Topo doesn't work as well. Everybody says generics work as well. About 6 months later, there was the FDA or somebody discovered that this particular generic Topo didn't work as well. There were problems with it. But doctors will form judgments on that. And the other thing is, how are you going to get doctors to care about it? Because the usual way you get doctors to care about it, in theory, is you put them at risk for the total expenses of their patients, whether in the context of an ACO or some sort of capitation contract or whatever. And while that may get doctors thinking about, well, I should find a cheaper way to do this. If we're going to do the knee replacement, we should use that knee as opposed to the other plastic knee or whatever. It may just get doctors just trying to avoid services that people actually need because their doctor's income is being put at risk. So many of the theories of cost control that rely on doctors turn patients into problems. A patient becomes not a person to be helped, but a cost center. I know it sounds like good economic theory, and there's all sorts of people going around saying that we should do that. But when you realize how you've changed what the patient means to the doctor potentially, it looks a lot dicier. Other questions? Come on, I talked for an hour. I must have said something to provoke somebody. Or did I act so sure that I must... That was a good trick. I'm so sure I must be right. He's sure, why should I ask a question?
So I have a question.
Yeah.
So given what we know about different health systems, is there a particular approach that you think we should use in the U.S. system, either to control costs or to try to address some of the inequalities within the system?
Well, I think I've said the things that I think are most important, which are to standardize the prices at a lower level and to get rid of the aspects of the insurance system which create extra administration. If you compare the United States to other countries, whether it's the OECD making the comparison, or it's people like Jerry Anderson and Uwe Reinhardt making the comparison, or whether it's McKinsey and company making the comparison, what stands out is not that the U.S. is sicker. Yeah, we're sicker in some ways, we're fatter, but we smoke less, and drink less, and we're younger. So it all cancels out. It's not that the U.S. Does more services. Yeah, we do more MRIs than almost everybody else, and we do a whole bunch of tests more than other places, but we put people in the hospital less. People go to the doctor less. When we put people in the hospital, except for a few countries, we keep them there less. So so again, if you look at volume of services, it ain't volume. It's prices, and part of prices is actually the administrative overhead, because so many things are created by having multiple insurers competing with each other, trying to recruit healthy people, but not sicker people, trying to design a different health plan for every employer. I mean, there's just, so between the underwrite, and then having different prices for everything. So that, it's not the Cleveland Clinic's fault that it has 1,600 billing clerks. It's our insurance system's fault and the non-standardization's fault. There's a bunch of different ways of doing that. Again, I don't think you have to choose between Germany and France or whatever. If the question is which system is probably the best, where would I rather live? It's not a great question, but maybe France. If you look at that amenable mortality table, they did best. The WHO, for its own bizarre reasons, the WHO, I would not rely on WHO for a whole bunch of different things, and that particular report was questionable. They rated them best, but they might have been right. There's lots of high technology. There's lots of doctors. We don't have many doctors. They got lots of doctors, so it's a little easy to see the doctor. You're more likely to see the doctor instead of 3 nurses before you ever see the doctor. There's lots of technology, there's lots of doctors, very good statistics. They've got a lot of social inequalities to deal with. And I'm sure they don't handle them perfectly. I mean, obviously, I'm sure that the people in the 7th arrondissement do better than the people in Saint-Denis. Just as an example, out there in the other banlieue with a whole bunch of tower blocks with North Africans and so on not living the greatest of lives. I'm sure there's a big difference. But on the whole, they probably do better. And I think it's partly because they spend money. Not as much as we do, but they spend about as much as anybody else. Partly because they're not a single-payer system, but they're closer to it, so there's probably a little savings from that compared to, say, the German system. They haven't done much competition. Partly they're the French, they're elitist, and they work very hard at doing certain kinds of things right. So if I had to guess, but partly that, again, there are little cultural differences in places. And maybe the French have a better attitude towards some of this stuff. But the differences between the United States and so many other countries. Now, I would rather, I'm not saying these other countries are perfect. The Canadians should spend more money and have more supply. The Australians have a really bizarre mix of private and public. But a bunch of countries do better than we do. Again, they're trying to sustain what we don't have. Yes, sir. Wazoo.
Yeah, I just got back from Washington State. But I was actually just curious if you had any thoughts about the recent ballot measure in California and the sort of dispute. I think it was over Medicare for all.
Which lost horribly.
Yeah.
Look, aside from the fact that there's a whole bunch of people who have a great amount of stake in having the system be sustainable for the providers as opposed to the patients, and who can spend a great deal of money There are some basic problems with single payer trying to sell it to voters. Remember what I said earlier about less visible taxes? There's a whole bunch of money that employers are currently spending that people don't see is coming out of their own pocket. Now again, a lot of economists will say it is coming out of their pocket. Again, they're partially right, not as right as they think they are, but they're partially right. Given going to single payer, going to anything where you're replacing the current money from employers with taxes, means you have to make a whole lot of invisible contributions visible. And how do you do that without looking like you're having a massive tax increase? And it's a risk. You know, the Obama people were right about something. All the single-payer people were upset about the strategies the Democrats had. But it's very clear that people are scared of change in something that's that important. And the tactics of not changing people's insurance. We're only going to change the insurance of the people who either don't have any or have insurance that is so damn terrible that they shouldn't want to keep it. So remember Obama's famous, you know, if you like the insurance you have, you'll get to keep it. There was always a white lie. The white lie, it was an overstatement. If your insurance is really awful, we'll replace it with something better, and you really should be able to figure out this is better. And because there were a lot of awful plans in the private market before. But people are scared. They're used to what they have. And to say we're going to go from what you have from Case Western, or from Ohio Wesleyan, or from Timken, or whatever, to this new government plan, first of all, you have to like the government to trust that. Trust the government to like that, or whatever, trust the government to trust that. But secondly, you have to not be too risk averse, because it is a risk, it is a change. So you have to deal with both the risk aversion and making the taxes visible. And those are both really hard. I don't know enough about the California initiative to know why it lost, but I sure bet there were a lot of ads of that sort. And I bet there were a lot more ads, you know, obviously against the initiative than for it. And again, we're seeing a version of this in Ohio now in a much smaller way. I mean, issue 2 is being fought with a fear campaign. It's a fear campaign that they've managed to get every other major interest group in healthcare to go along with. The basic argument, remember in issue 2 doesn't have anything to do with most people's health insurance, drug prices. It's only about the state government's prices. What it says is that the state government will pay what the VA pays, somehow, if we can figure out what the VA pays. Maybe that means the state government would pay less. What are the arguments against it? It'll raise prices for everybody else. Why will it raise prices for everybody else? Well, because the drug companies will raise prices for everybody else. Who's telling you it's bad because the drug companies will raise prices for everybody else? The drug companies. Why is everybody else, and why are the nurses and the veterans and the doctors and so on endorsing it? I think they're endorsing it. Well, I'd really like to know. I don't think they're going to tell me. I don't know if they're going to tell me if they're going to have any contributions from pharma or whatever. But one thing is, this is really an argument about the principle of price regulation. And it's part of all the side issues about Michael Weinstein and all that, who by the way, is a really unusual fellow. And there's a great story in the New York Times magazine about him back in April. It's what's going on here is, I think, that this is about regulating prices and the government taking a harder line on prices. And the doctors and the hospitals don't want to see it get started. So all the providers are against single payer because they think it'll affect the prices. And You may have heard of all sorts of other theories about cost control. And by the way, any theory of cost control means less income for somebody. If we stop all the unnecessary care, somebody was doing unnecessary care. They're losing income. They shouldn't like that. But nobody knows exactly who's doing the unnecessary care. You can think it's not me. Right? We're all better than average. And nobody knows how well that will work, because in general it hasn't worked very well. Everybody knows, all the providers know, if you crack down on the prices, that affects them. So between the taxes, the visible taxes instead of invisible contributions, the fear of change, and the providers hating the idea, that's a lot to get past. Might be better for the rest of us, but thank you all very much.